Well, welcome again, everybody, to the Conversations in Interventional Cardiology. My name is Frank Ng. I'm Associate Editor for JSCAI and Chief of my division at UC Davis. I'm honored to represent JSCAI and the Editor-in-Chief, Dr. Alexandra Lansky. Now, we're here to discuss an important document published in JSCAI entitled 3D-RA to Guide Cardiac Catheterization in Critical Infants, 5 kilograms of body weight or below. I have a distinguished panel here for the discussion. The presenting author will be Dr. Chenise Lucas from the Wilhelmina Children's Hospital in Utrecht, the Netherlands. Senior author is Gregor Krings, also from the same center. I have another panelist, Dr. Howaida El-Said from Rady Children's Hospital in San Diego. So with that, I'm going to have Dr. Lucas present the summary of the paper first, and then we'll launch into a discussion.
All right. Well, thank you for the opportunity to present the results of our manuscript. I will be telling you about the use of three-dimensional rotational angiography to guide cardiac catheterization in critical infants with congenital heart disease and a body weight below 5 kilograms. Three-dimensional rotational angiography has proven to be an advanced imaging technology performing computed tomographic angiography during cardiac catheterization with computational conversion of the rotational angiography into a volume rendered data set. This data set offers high spatial resolution and is taking tissue characteristics of different Hounsfield unit ranges into account. 3D-RA allows for unrestricted virtual angulation of the target lesion or region of interest, which is usually not achievable when using regular biplane angiography. Particularly beneficial is the fact that advanced guidance of interventional procedures is facilitated by back projection of the 3D image as a 3D roadmap on the conventional angiographic system. So despite evidence of superior imaging quality in 3D-RA, it is still used with restraint in neonates and small infants, considering they're often in critical conditions. If catheter interventions are indicated in these group of small patients, then biplane angiography is the standard to visualize and treat relevant lesions. However, although being complex, we believe that 3D-RA can be extremely helpful to understand and guide interventions in this group of small and vulnerable patients. So the purpose of our study was to analyze the utility, safety, and value of 3D-RA in the treatment of children with congenital heart disease and a body weight below 5 kilograms. So this study represents the 10-year experience with 3D-RA in our center. In this slide, an overview of our patient population can be seen. In our 10-year study period, we included 86 patients who underwent a total of 109 3D-RAs. Our median body weight was 3.8 kilograms. So we're talking about pretty small children right here. And in this slide, you can also see that we have a relatively high percentage of interventional procedures in our cohort. And that can be explained by the fact that we had a learning curve of 3D-RA in our center. So with the arrival of a high-end CT scanner at the end of 2018, 3D-RA was hardly used for regular diagnostic purposes anymore. And it actually switched to more interventional procedures. So to create an overview, we categorized the cardiac disorders into 4 main categories, and the most frequent diagnosis in our cohort was hypoplastic left heart syndrome, followed by fallow-like abnormalities and aortic lesions. This, in combination with our median weight, body weight of 3.8 kilogram, really delineates the complexity of our cohort and the vulnerability of our patients. And in our cohort, 3D-RA is mostly used in pulmonary artery or aortic or shunt stenosis, which requires stent implantation, or in embolization of large collateral vessels. So the most important finding was that 3D-RA led to important new information in nearly 71% of all catheterizations. So typical new findings were unexpected vessel stenosis or identification of a native pulmonary artery system. These concern findings that were not visible using regular biplane angiography or echocardiography. In our 10-year study period, only two major adverse events that were 3RA related occurred, both concerning ventricular fibrillation as a result of the usage of rapid ventricular pacing in these patients. And in both cases, cardiopulmonary resuscitation was successful and no additional interventions were necessary. So important to mention is that despite the high complexity and morbidity of these children, no deaths occurred during cardiac catheterization with the use of 3DRA. 3DRA was performed with rapid ventricular pacing in approximately 78% of all cases with a median pace of 220 per minute. And concerning the amount of radiation exposure, we found that the median amount of total radiation exposure during the procedure was about 160 centigrade per square centimeter, of which a median amount of 21% was derived from 3DRA. So important to mention as well is that at the end of 2012, major radiation adaptations were introduced in our center. So the mean percentage of radiation exposure derived from 3RA before 2013 was 51%. And since 2013, so after the major adaptations in radiation settings were made, that percentage has decreased to a median percentage of about 17.6%, which is quite a lot. And the median amount of contrast agent used in the initial 3DRAs was 28.5 milliliters, but we used a dilution ratio of saline to contrast of 60% to 40%. And that translates to a mean of 4.8 milliliters of pure contrast per kilogram. And contrast was usually simultaneously administered at 1 to 3 locations. And in most cases, 2 contrast administration locations were used at the same time. So all of this being said, I would like to present a case in which 3DRA made a substantial difference, in which 3DRA was a true eye-opener for us. And that concerns a 3.8 kilogram weighing child with hypoplastic left heart syndrome, who was at day 10 after Node 1 surgery with implantation of a Zano shunt. This child was hemodynamically unstable and showing saturation levels of around 50% despite being ventilated with 100% oxygen and nitric oxide of 20 parts per million. So, of course, we performed echocardiography, but echocardiography showed a good right ventricular function and an unobstructed RVOT to a Zano connection. So the only thing that the echocardiography did show was a turbulent flow in the Zano to pulmonary artery anastomosis. So then biplane angiography was performed in multiple angulations, of which you can see 2 images right now on the screen. And on these biplane angiographies, there was no evidence for uneven contrast distribution, no stenosis or pulmonary hypoperfusion. So although this child was oxygen and nitric oxide dependent, which usually demands restricted use of contrast agents, we did decide to perform a 3-dimensional rotational angiography to better understand any potential problem, because up to this point, we had no idea what the cause of the severe desaturation was in this child. So in this slide, the setup of the 3DRA that was performed is demonstrated. A 5 French long sheet was placed into the right ventricle, and through this long sheet, a 4 French pacing electrode was advanced into the apex of the right ventricle. We then performed the rotational angiography with rapid ventricular pacing at about 230 per minute. The workflow of the rotational angiography is as follows. You stop ventilation and then you start rapid pacing. And then you manually inject a contrast through the long sheet into the right ventricle. And at this point, we use a contrast dilution ratio of 60 to 40, using only 40% contrast agent and 60% saline, as I mentioned earlier as well. And we administered 24 milliliters of contrast in with a flow of 4 milliliters per second. And after a 1 second pre-filling of the ventricle, the rotational angiography starts with the C-arm rotation taken at 5 seconds. And immediately after the angiography is completed, pacing is stopped and ventilation is resumed. And during the first minutes following rotational angiography, cardiac rhythm, CO2, and blood pressure have to be monitored carefully. And the first image that you get is the black and white rotational angiography, which you can see right now, and that visualizes all structures in the region of interest. At this point, you have to post-process the images that you receive, and the post-processed 3D volume data set that we have right here shows the aortic anatomy in silver and the Zano shunt, the pulmonary artery connection, and the single ventricle anatomy in yellow. So in this case, I will show you the video 360 degree. In this case, you can see that the stenosis of the Zano to PA connection only gets visible in a straight caudal angulation, and it is hidden in any kind of standard projection, which of course explains why previous biplane angiographies could not identify the hemodynamic problem. So following this rotational angiography, we back projected the 3D anatomy onto the conventional AP plane and performed implantation of a coronary stent in the Zano to RPA connection, which you can see being done right here. So the 3D anatomy is used as a roadmap to perform implantation of the stent. And very good to mention is that this child improved within the next few days and successfully underwent PCPC a little later in life. So in conclusion, our patient population below 5 kilograms of body weight is characterized by its complexity and high percentage of emergency indications of the cardiac catheterizations. And even in our complex patient population, the use of 3DRA in children with congenital heart disease and a body weight below 5 kilograms proved to be safe. We saw only a few complications in which in 2 patients ventricular fibrillation was induced by the use of rapid ventricular pacing. And these patients already had high right ventricular pressure load as a result of severe pulmonary artery branch stenosis. In our opinion, rapid pacing is essential to decrease contrast flow by reducing cardiac output. However, if the cardiac output is already decreased in patients due to poor ventricular function, then rapid pacing might be unnecessary, but that's only in these indications. And to enable safe workflow using rapid pacing, creating awareness of the potential development of ventricular fibrillation in patients is necessary. And preparation should be made prior to the catheterization, ensuring essential equipment such as defibrillators are within reach, and this can guarantee safe practice of 3DRA with rapid ventricular pacing in these patients. So in comparison to different studies performed on different study populations, the amount of radiation exposure and contrast agent used in our cohort was relatively high. However, in our 3DRA learning process, major radiation adaptations were introduced in December 2012, leading to a remarkable dose reduction in 3DRA. And up to this point, one biventricular 3DRA accounts for only 70% of the total radiation exposure. So we are making progress when it comes to radiation exposure. There are considerable limitations to the usage of 3DRA. First of all, the workflow of performing and post-processing high-quality 3DRAs is complex, and it involves cooperation and good knowledge of the entire team, and working together in a manner that is good for everyone. Also, the volume data sets that are derived from 3D-RA, they only contain static image information, whereas biplane conventional angiography is dynamic. And that means that both techniques address different and complementary types of image information. And at this point, they should be used together to ensure the best results in our patients. So that is what I wanted to tell you this evening.
All right. Well, thank you for presenting that. Excellent presentation, Chenise. Let me start with a couple of questions and feel free to answer, and Howaida, please jump in. 3D-RA has been around for at least a decade, but you guys have taken it to another level regarding the frequency of use and so forth. Personally, I found that I can find a stenosis, especially if it's not without 3D-RA. I mean, you showed that example, and I thought I saw on the lateral a stenosis at the distal sano, which was close to the RPA. Granted, the 3D-RA did show the stenosis and RPA much cleaner after you've done that. So I can see some value in it. I guess my question for you, especially is, given some of the limitation, as you mentioned, that dynamic data is lost, the workflow can be quite complex. Have you, over the 80 cases or so you've done, have found out if there are certain anatomic features that are much more, where 3D-RA is much more useful compared to others? In other words, what kind of lesions would you hone in on, say, this is definitely going to be much better assessed using 3D versus other types?
Yeah, that's a good question. I think that when you're talking about aortic arch stenosis or something like that, you can use CT scans as well to understand the anatomy. However, when it comes to stenosis of the pulmonary arteries or shunts, they usually have a very complex, complicated course. And with 3D-RA, it's much easier to orient and to really depict the right angulation, and also immediately determine your approach in the intervention. Let me know if I'm incorrect, but I think especially in pulmonary artery stenosis or shunt stenosis, 3D-RA is particularly beneficial. Yeah.
I found that the times when I have some trouble are going to be the osteal lesions in the branch pulmonary arteries, where the proximal segment is dilated and it's superimposed on that narrowing. You might not be able to see it. I also find that sometimes in the complex coarcts, that could be very helpful, as well as the tortuous ductus. But I have to say, I have not found myself unable to diagnose it with conventional for the vast majority of stenosis. I need to ask another question. In your paper, you talked about having the average of 4.8 cc's per kilo use of contrast. My question to you is that a lot of times these is a one giant bolus of contrast that you give in the 3D-RA. That's different from when we do biplane angiography, where we're giving contrast over a longer period of time. Again, I remember talking to Chuck Mullins in the past where we always use 6 cc's per kilo as the maximum, but actually, if you do this over 4 hours, more contrast is already in the bladder, so therefore it's not in your vascular system. This is different than when you give a giant bolus of 3D-RA. Have you noticed any type of renal dysfunction, even if it's temporary afterwards, when you give this type of bolus within a short time, as opposed to the stretched out time with many biplane angiography? What do you think?
I think I should take over for the renal part, since Chenise did a great job to join us with this specific 5 kilogram stuff over a year. So now looking back over 14 years, no, we didn't have any renal problem. And I totally follow you. We have to reduce, of course, contrast and the amount of radiation. That's why we just pretty worked hard in the first years. We are now, if you want to know about the Iconos system, we are now down to 1.5 milliliter of contrast per kilogram, but this is just due to Icono and would not be reachable with the RDC or with the older systems. So we had no renal trouble. And I think if we are fair, I just went through a couple of cases of pulmonary atresia after unifocalization or shunt children. I agree. If you do your job right and you're a senior, you will find the stenosis, your angulation of your SAN or BT shunt or complex pulmonary artery bifurcation, refocalization. But honestly, I think it will take you, Frank, 2, 3, or 4 biplane angiographies. And if we honestly count the amount of contrast we give in the 3, 4 biplane angiographies, then we are at 1 3DRA, especially if I now go down to 25% of contrast in the newer system. However, I'm with you. We have to reduce radiation and amount of contrast. And at the beginning, it was pretty high, 80%, 100%. And now we are really very low. So I think if you compare to biplanes, I think we have a good deal there.
Howaida, did you have a question?
Yeah, I had a couple of questions because this spanned over a long period of time. So, and you showed very nicely how you reduced radiation and contrast over time, and so that is really great. Another philosophy was, which also with the Siemens system could be feasible, is that you do a CT scan ahead of time, and then you overlay the CT scan over the images rather than do the 3D rotational imaging in the cath lab. It has an advantage if you've had time to analyze and work through all of the, what you're going to do, and then you can do your angulations. I think also, if I understand correctly, when we do a CT scan that's not a 3D rotational spin, they give like 1 per kilo of contrast. And I think it's probably about the same amount of radiation, maybe less. Have you guys adopted that because you have the Siemens system, so it allows you to do that? Or do you always just resort to a 3D rotation?
I think Chenise knows one of the answers because, as she said in the talk, we had really like historic data in the beginning. We didn't have our Siemens Force CT or whatever kind of modern CT. So we had a CT which really gave us like this 1 millimeter, 1.5 spatial resolution, which was unacceptable. So you wouldn't see the pulmonary artery with this native system. So this is where we came from with 3DRA typically. And our MRI, of course, was the same. I didn't have any MRI guy as in London, which would pop up a 3-kilogram MRI with a child lying on mommy's chest. So over the time now, when in 2017-18 we got the Force CT, we evaluated the radiation of the Force CT, which was 0.4 millisievert per left ventricular, so just a normal chest CT. And we had a second radiation paper on our 3D in 2013, where we did a Monte Carlo angle-wise, very accurate calculation. And we went from the initial 3-4 millisievert to 0.4 to 0.7 for a biventricular 3DRA. So now with the Icono, I'm down to 30% of this stuff. So I'm somewhere around 0.15 to 0.2 millisievert. So the second thing is, you're absolutely right. Now, since we have the CT, our standard, if we don't go for CAS anyway, if we don't go for CAT anyway, is a CT. If I know I go for CAS because the sinus shunt seems to be bad or whatsoever, I just do the 3D at the CAS lab, because you are right. You would have time in advance to take your CT and study, which is so important. I mean, just to learn all the anatomy. Again, if I have a CAS indication anyway, then I do a 3D because of one reason. I don't have to cut all these pulmonary veins away. I'm just right in the pulmonary arteries. I don't have to cut these veins away for hours when I look for the third generation, where our senior surgeon did do this unifocalization or stuff like this. So simple cases, totally with Frank, biplane, that's it, echo, you do it. The more complex, especially PAs or kinky arches and shunts, where I know I have to do something, then we go for 3D right away.
Gregor, you mentioned in the paper almost 50% of these cases were done on a sort of an emergency setting. And I'm assuming some of these are going to be the unifocalizations. Do you guys routinely do exit angiograms in the cath and the OR so that you don't encounter an emergency? You kind of know in advance and they can do the revision at the same time.
Yeah, great question. And again, I think, Chenise, I should take over. But again, let me give you the credits, because being a student at this time, like a year, 1.5 ago, you gave us great information, and I have lots of respect for the knowledge you built up in this time. Frank, yes, we do exit angiographies, and they were the hard price and the learning curve. We were, over the years, the only center in the Netherlands to do the hypoplastic left hearts. And yes, we were tired of these surprises. So we don't do an exit as a shunt, after a shunt, but we do an exit after Glenn and Fontan. Not in a shunt. So we just look at the shunt clinically, and if the shunt deteriorates and goes down, then we go for CAS. And second thing is, what I love to our surgeons, what we didn't have in Berlin, we don't start with a shunt 4. We go for a shunt 3 or 3.5. So we like to have the child, let's say, normal perfuse on the lung. So I luckily don't experience children which have hyperperfusion, which on the other hand means that by month 3 or 4, I have pretty much, well, probably like 25% of the kids where I have to enhance the shunt by stenting it. So we like to stay low in pulmonary perfusion, not to hyperperfuse, not to have low systemic output, but we pay the price that like over a month or 3 or 4, we sometimes have to stent the shunt, and we like to do a Glenn in 5 kilogram or 4.5 early if necessary. So yes, exit angio in Glenn Fontan.
Thank you.
Can I ask a question about, in your Siemens system, you're doing it only with the single plane, the rotation is with a single plane. Are you going to have the ability to do it with the biplane? And if so, do you think there are a lot of advantages, maybe use less contrast?
Yeah, that's a fantastic question. I think that's what we all are waiting for, whatever vendor we are addicted to. We bought our Icono system now in 22, so like nearly 2 years ago. And when we bought the system, I saw that we would get the biplane acquisition and biplane iPilot within 2023, but we will get it next year in June, which is 25 in June.
So, we're in the same boat. That's why I'm asking.
So that's it. So, I mean, I saw this in Forchheim in 2018. However, we're going to get this. And there's one interesting thing, Howaida and Frank, which I really like to this. It's not that it spins with both planes and just going to be faster, like 2-point-something seconds. Mm-hmm. But one thing I would love to see, which we did in 2015 to 19, if you take a retrograde ECG gating of your 10 years old rotational angiography without any extra radiation, just retrograde gating, and you have at least 10 cardiac cycles in your entire rotation, which would mean that you have to rapid pace. Then we had the study where I converted every 3D into a 4D. So I had a Yasui, a Nikaido, an RVOT, or like a small coarctation, but especially, of course, outflow tracks, which were dynamic, with no extra radiation. So now if we would have biplane acquisition, I don't have to rapid pace anymore. I just will do a 5-second spin with biplane, ECG triggered. I will have the same radiation as before, but I don't have to pace. So I will have physiologic contraction patterns. And this is where I want to go. It's going to take some time to get Siemens into this pathway. So probably will help. But this is my real perspective. I mean, of course, we both want to have biplane roadmap for PPVIs whatsoever. Yeah. But what I'm really essentially looking for is having dynamic 4DIA with the same price of radiation. And then that's going to be just, I think, a game changer.
And you ventricularly pace, or do you ever esophageally pace?
Yes, of course. Well, first, this was a learning curve too, because I got one of the old pacemakers, old EP, with 3 drivetrains, and this one of these, LCD liquid display things. We found them somewhere, and since I did EP for 2 years in Hamburg, I just thought, let's pace and use this stuff. And so we had a very high output, long duration, and high impulse amplitude, and we have perfect pacing, I would say up to 20-25 kilogram. So we use a 4 to 6 French esophageal, and then we pace this big metal chunk stuff. Mm-hmm. And of course, in the TCPC, when we do our airway ovalization whatsoever, I really like to have crispy, sharp edge control or noise ratio control, and then we do pacing too. So that's when we use esophageal. So in the 2 kilogram, or in the 3, or in the 5, or in the TCPC, I love esophageal pacing.
Are you also reconstructing the bronchus to look at the relation with the branch, the LPA and the aorta? Because you can do that also on the Icono. So that's a nice feature too.
Yeah. Alison contacted me last week by Amy, and she had her first Mayo bronchus compression, and well, you know the story about Oval, and yeah, it's still probably if I would have to say one thing on the 3D rotation story over the last 14 years, I learned anatomy. Point. And I think if I probably would not have been wiser now by finding Frank's angulations to Sano in a second, I think one thing my team learned is understand anatomy, understand collateral damage, defocus. I mean, we all are told that you put an LPA stent into an LPA stenosis. But I was not told by Hausdorff and Berger and who all these guys were that there's a bronchus behind this. And then there's even a pulmonary vein. So I think if there's one thing I really love about this entire 3D road we went is learn anatomy. And this is probably something I would like to teach people.
I know we're running to the end of the discussion, but you have this unique multi-location angiography using your Can you go over that a little bit just to help us get familiar with that, what that means and where is that applicable?
I think one key setup for to visualize multiple cavities is what we learned early, that you would have to have the Siemens system. Sorry, not because I want to push Siemens, but the Siemens system has a double image channel, which we just found out in 2012 that it was useful because it was thought to take a CT and put it onto a 3D rotation. So the crazy thing on this artist and Icono now is that I always say you could visualize the right and the left ventricle, I would say the thumb and the fingers. So I would give contrast right ventricle, left ventricle, because I want to see all in one. I don't want to have two rotational spins. I don't want to have radiation twice. And then with the Siemens system, Frank, I would duplicate my hand, put the thumb to the one data channel A and the fingers to the channel B. And the magic is that it would be like two PACS workstations. I would have two different Hounsfield workspaces. So I would be allowed, as we do since 2011, I would be allowed to use more like a soft tissue Hounsfield for the pulmonary arteries because they are spreaded, they are branches, and a much higher Hounsfield for the aorta because it's just a simple tube, bang, and the contrast gives you a nicer noise ratio. So double channel, this is what you need to have the benefit of multiple location injections. Otherwise, it wouldn't make sense to have multiple contrast location injections. So if you have a system like this, I would strongly advise to do multiple location injections because take a Glenn, jugular, single ventricle, and if you think you need it, you could also put some contrast in the aortic arch if it's a complex DKS in the Glenn. So we do both jugulars because I don't want to mess around after the 3D and look for collaterals by selective angiography. I don't want to, you know, have added all this extra contrast. I want to have all the information in run. This is why we do multi-location, and then we really use this double image level. I also could use 3 for this workflow.
Sorry, when you say double image level, are you using different contrast percents in the different chambers so that you can have them look differently?
That's a very good one. No, I don't need double contrast. I really have two independent Hounsfield unit platforms. You have the artist and now you have the Icono, right? So if you have the Icono, you have an A and a B. So just next time if you do it, just duplicate the 3D array you acquired. Or if you want, just give me a call and I look by whatever kind of teams. So you duplicate your rotational and it will give you two different independent Hounsfield ranges where you can play with. And why it is so important? I mean, normally if you do the same amount of contrast right and left ventricle, just due to the different resistance, the different dynamics to the pulmonary perfusion versus aortic perfusion, you will have more gray in the pulmonic and more white, or call it black, whatever you want, in the aorta. So if you want to address this difference in Hounsfield, you need two independent image levels. And if you did this once, what I mean with finger and thumb, it's just very, well, it's just a good performance you get by working independently.
You should actually write that up on the techniques and the protocols for the multi-location imaging. Lastly, one more final question is a practical question. Since this is really require a team to put this together, how many cases did you guys do before the team all felt comfortable with the workflow?
One of the major things, I think, Frank, when I met you first in 2012 at SCAI, and I think I asked you, oh, you do 3D? I think you or somebody else told me that your technician with whom you did 3D left. I think something like this happened. And I had this in mind when I went to Lee in Toronto in 2012, January. I want to see how Lee is doing this. And when I saw Lee, when I listened to your story, I knew that all of our 3 staff people, our doctors, our physicians, they have to learn how to do the 3D. This is what we do until now. So I don't have technicians running around like 4 or 5 or 10. So our doctors, our physicians, they know how to do 3D. How long does it take them to feel comfortable? Should I be honest? A year. A year. Because if you know it, you would still not have the feeling to be comfortable in using it, right?
Yeah.
And I think people of my team would still probably in some cases prefer to do black and white, because Frank says you can see everything in black and white, and they will end up with 5 or 6 biplanes. And Gregor will shut up in the background and, not suggest the 3D. So it takes a long time with everything, right? To feel comfortable. How long does it take to feel comfortable to put a dry seal 26 into a 30-kilogram child? I don't know. So it takes some time.
Okay. Very good. I think this was a very fantastic interactive discussion. I think we're at the end of the time. So thank you very much for participating in this wonderful discussion. Thank you.